Muhammad Amiruzzaman, and Dr. Amiruzzaman is cornea and refractive surgeon at Bangladesh Eye Hospital and Institute, Dhaka. Welcome, Dr. Amiruzzaman. And as speakers, we have Dr. Ashraful Huq. Dr. Ashraful Huq, I've known him for the past few years. This young, dynamic, ever smiling guy who first came to our collaborate, I think, in Kolkata and floored everyone with his wonderful presentation. Welcome, Ashraf, and we expect great presentation from you. Dr.
Thank you, sir.
Maziba, you have been anchor in this collaborate, and the amount of work that you have given to collaborate is phenomenal. I wish to give a special thanks to you. Dr. Harun Rashid, sir, you've been one of the pioneers of refractive surgery in Dhaka and head of Department of Ophthalmology, Shahid Sh- Sh- Shurawadi Medical College in Dhaka and a senior consultant in Dhaka Eye Care Hospital, Dhaka, Bangladesh. Thank you, sir, for being a speaker in this session. And we have Shayan Das. Shayan is a brilliant cornea surgeon. Refractive surgery is peanuts for him. So trained in PGI Chandigarh and right now at Shushrutai Foundation. Welcome, Shayan. Last but not the least, and the person who has done all the homework is Dr. Siddiqur Rahman. Dr. Siddiqur Rahman has done all the homework that was needed for this cataract and this refractive surgery session. Welcome, Dr. Siddiqur Rahman, and we are very, very proud to have you with us, glaucoma specialist and refractive surgeon, managing director and consultant, Vision Eye Hospital, Dhaka, Bangladesh. So, right from cataract to glaucoma, you practice a huge gamut of the surgeries. Thank you for being a co-moderator with us. Over to you, Siddiqur.
Thank you, sir. Sir, you Artha, sir.
So, yes. So,
Sorry, you introduce Ashraful Huq as
yes.
and invite him to
Sure.
present, please. Sir.
So, Ashraf, do you need any more introduction? Do you need any more great words from us? If you do, then we are here for the whole evening. But we are very, very keen to hear your presentation, Ashraf. And over to you. Welcome.
Thank you, sir. Thank you, the Collaborate team, for giving me the opportunity for this. I have sent my presentation. So, backend team, can you please?
Chairpersons, panelists, and moderators and delegates. Very good evening to you all. LASIK is the most popular and common refractive surgery. Patient satisfaction is found around 95% after LASIK. For all refractive surgery, we need to have more chair time, counseling, and proper pre-operative evaluation. Remember, we are treating a normal eye. Patient expectations, occupation, contact lens history are very important before LASIK evaluation. Avoid LASIK when patient is pregnant or we have any systemic condition like diabetes or autoimmune disorders. Stable refraction is must. Patient age over 18 years and no change of refraction for at least 1 year is needed. Corneal topography evaluation, ocular surface disorder evaluation, treating the dry eye and excluding any corneal epithelial disorder is must, and also need to check that patient has no glaucoma or retinal pathology. In Pentacam, I evaluate 12 points. Among those, keratometric value, corneal thickness, signs of any formifused keratoconus in elevation data, Berlin embryo enhanced ectasia display are very important to evaluate. Also consider pupil size and white-to-white data. Finally, data input need to be correct and rechecked. Residual stromal bed should be more than 300 micron so that the correction in LASIK should be done with counseling of the patient after the residual stromal bed 300 micrometer in case of high refractive error. For simple understanding, LASIK steps we can divide into 3 steps: making the flap, flap lifting and laser, and at last the flap reposition. The traditional microkeratome flap is done by oscillating blade system. A lamellar corneal flap is done while the cornea is held under high pressure. In case of femtosecond laser flap, after proper docking, when we make the flap, thousands of tiny bubbles due to microcavitation is created in a raster pattern, making the interface between the flap and the stromal bed. The comparison between the femtolaser flap and the microkeratome flap cutting in case of LASIK, the femtosecond laser system offered a significant advantage over the mechanical microkeratome. The flap lifting after the femtosecond laser is done by most carefully and gently with the patient cooperation to prevent any unwanted complication of flap. And this flap is lifted and the stromal bed is ready for laser. Examinal laser machine has the pupil tracking system. We have to fix it before firing the laser. After the eye tracking is done, laser is fired. What the data is entered for corneal reshaping. And after the laser, cleaning of the stromal bed with irrigation is done. The proper cleaning is needed. And after the cleaning, we reposition the flap, and this should be properly repositioned and carefully done. And all the LASIK steps are done now. And at the end, we need to be always careful in the operation area that we are doing the right patient, because the data entry and the patients are same, the proper eye, and obviously recheck the data which have entered in the machine. After the LASIK operation, the steroid, low-dose steroid and antibiotic need to be given for 3 weeks, and artificial tear need to be continued for 6 months, and patient need to follow some advice for 2 weeks to 1 month. And careful evaluation and surgical steps can make a LASIK patient 100% happy. Thank you very much.
Thank you very much, Ashraf. That was excellent in a nutshell. You have taught us so much about LASIK. I would request Dr. Sagar Bhargav for your comments. Sagar?
Yeah, can you hear me?
Yes, please.
Yeah, good evening. An excellent presentation giving a nice overview about the whole preoperative workup for a LASIK patient. A couple of points would I probably like to add. The refraction in a relatively younger patient should be a cycloplegic refraction, because there is a risk that the patient may have a pseudo-myopic element there. So that's something that probably I will add on that. With regard to pentacam analysis or Scheimpflug imaging, all of us essentially do that. But one additional thing which probably helps me in my practice is what we call it as inter-eye asymmetry score. This was a very interesting paper that was published in 2015, which basically spoke about the 5 characteristics, and you basically compare the 2 eyes and give points based on the asymmetry score. And if you are beyond 3 points that are not matching, I'll probably look at suspicion for those cases. So probably these 2 points I would like to highlight.
Thank you very much, Sagar. They were excellent points, and I think that article should be read by all of us. And this scoring system is very, very valuable. And I would like to request Professor Zafar Khalid for your comments and your collation of everything that Dr. Ashraf has said. Dr. Khalid, sir?
Please unmute yourself.
Unmute, please, sir.
Yes, I've done. Can you hear me?
Yes, sir.
Thank you very much. Thank you. Thank you, Dr. Ashraf. You have given a very nice presentation in a nutshell about the LASIK. And most important part of the LASIK is the patient selection, as you have already mentioned. And also the patients, now the patients are very sensitive about the latest technology. So whenever we are doing a counseling to the patient, they will definitely would like to know the advantages of the doing LASIK when the other refractive modalities are available. So it is definitely another art to make them convinced why I want to do the LASIK instead of doing other refractive surgery, why I'm not doing PRK, why I'm not doing SMILE. So every patient must have must be convinced that the procedure he's going to have is the best for him. So that's why giving the technologies and everything, we must be very confident why we are doing it, and we must convince the patient before we proceed. That's what I want to say at this moment. Thank you.
Thank you very much, Professor Khalid. One small comment, if I could make, and Ashraf showed two very beautiful videos. One with the microkeratome LASIK, I think it was the Moria microkeratome that was working, and the other with the femtosecond laser where he created the flap. I think all of us watched very carefully with the Moria microkeratome, the applanation zone, and when the blade was going across, I was missing a beat whether Ashraf would actually show a complication of a free flap, or would it be a flap with a small hinge. So obviously it was a well-made flap, but this is where the possibility of the femtosecond laser is important. And femtosecond laser scores above this in this part, that the amount of safety it gives for a possibility of a free flap is much higher than the microkeratome. However, the studies have shown that the outcomes of both the microkeratome as well as the femtosecond flap is the same or does not have a statistical significance difference. So, but wherever the safety features are concerned, the femtosecond flap definitely scores over. So thank you very much. And I request Dr. Siddiq